And so I'll just, I don't think anyone needs an introduction to COVID, but for venous thromboembolism, that's basically blood clots in any part of the venous system in the body. And in this study, we specifically looked at blood clots in the lung and in the deep veins of the legs and arms. And these are the clinically most important blood clots, I would say in general and in COVID specifically, but you can clot in other places as well, but those are not studied in this context. So venous thromboembolism in this context would be primarily pulmonary embolism, or PE, and deep venous thrombosis, or DVT, in the leg. And this question stemmed from many different, or there were many different parts in this in the beginning of the pandemic. But in the beginning of April, so fairly early in the pandemic, there were 3 major studies published in close contact that all showed a fairly large or high prevalence of venous thromboembolism in COVID patients. And this was done in primarily ICU patients. So there were 81 in the first by Q et al., and then 184 from the Netherlands by Clock. And then subsequently 150 ICU patients from French by Helms. And all these showed quite similar prevalence of about 25 to 30%, or 20 to 30% of patients in the ICU having blood clots in addition to their COVID infection. And this was substantially higher than what we usually see in ICU patients. So the best cohort, or the largest cohort at least prior to this, would be the PROTECT study that had 3,700 people, general ICU patients with prophylactic treatment for venous thromboembolism, and they had a prevalence of about 6%, and that would be the norm, sort of, to have 6 to 10% of venous thromboembolism for ICU patients, because they tend to clot, but not that much. So this caused quite a lot of questions, and the COVID itself was new and unknown. So naturally, people were interested in this. And just for comparison, we was a little bit concerned in the medicine department about this as well. We dug up some studies, because this PROTECT study was general ICU patients, and the COVID patients in the ICU are definitely no general ICU patients. I think Michelle would add to that. And so we found 2 other studies, one by Obi et al. From the H1N1 pandemic, and that was consecutive patients in ECMO ICU in Ann Arbor in around 2009, I think. So they had 71 severely sick patients in RDS, so severe respiratory failure in the ICU. And they had the prevalence of about 40%, despite accurate treatment for venous thromboembolism. And similarly, in another cohort from 3 ICUs in Ohio, with 105 consecutive septic patients, they had a similar prevalence of about 40%. So we were a little bit suspicious, because or thoughtful that maybe it's not primarily the COVID that drives this venous thromboembolism, but rather the sickness of these COVID patients in the ICU. But that was the data. The data in the beginning of the pandemic was a lot from the ICU. But we, as emergency physicians, ICU patients are important, and we like them, or very sick patients, but they're fairly small number of patients compared to the other patients that we care for. So patients that we admit to the ward, or the even larger group that are not admitted to the ward or into the hospital at all. So how are we, with this new knowledge that venous thromboembolism might be coming with COVID, how are we treating those other groups? So this was why we wanted to conduct the study and try to sort of at least tease out more information about these two other groups primarily. So we designed a retrospective observational study. The cohort was any adult patient that performed the diagnostic test for venous thromboembolism, that would be PE in the lungs or DVT in the legs, between March 1st and May 23rd, 2020. The outcome that we were interested in was venous thromboembolism, basically, as I alluded to. And the exposure would be a positive test for COVID-19. And we defined that as a positive PCR test because that was the gold standard and still are the gold standard in our healthcare system. But we also know that there are certain other risk factors for venous thromboembolism. So we gathered quite a lot of other data to try and adjust for. And then we also thought that there is so much going on with the COVID pandemic, and we were doing quite a lot of things differently for many patients. We were doing less surgery, and people tended to not come to the hospital in the same extent as they did before. So, and this would probably affect our outcome. So we pulled the same data that we wanted for our COVID patients or potential COVID patients from 2015 to 19 as well to have some sort of comparison. And our flowchart looks like this. So between March 1st and May 23rd, and these are from all years, 2015 to 20, there were a total of almost 10,000 studies for VT done. So these are studies, not patients. This is important to understand. We excluded children, which was fairly few, referred studies, so those coming from outside hospital to our tertiary care university hospital in Linköping. And then we reduced the number of studies because some patients did one ultrasound for the right leg and the left leg at the same time. So we reduced those to one study instead. So the cohort was close to 9,000 patients, and 1,400 of these was done in 2020. We were somewhat surprised to see that we had only 88 studies or patients in this case, but because no patient did 2 studies, but 88 studies that had a positive COVID test and 546 that was negative, and another 764 studies that had no tests. So they were either not suspected or had done or could not have done a test because this was still quite early in the pandemic. So the number of tests was limited, and it was quite a high bar initially to get the test for COVID. So there was this, but the low number of positive cases was somewhat surprising to us. And we defined positive as having any positive PCR test 14 days prior to their diagnostic test for VT and up to 7 days later. So there was quite a large span of 21 days within having done the test to be classified as COVID positive. So this is a quick chart, and it's a lot of numbers, and the only thing I want to highlight, so these are 2015 to 19 and 2020, and then the subset of COVID positive patients. So the overall year cohorts were quite similar, and this COVID specific or COVID positive cohort were more likely to be male. They were likely to be admitted or be cared for in the hospital. And this is rather an example of the selection bias in this cohort, because the patients that were treated and had a positive test for COVID during the initial parts of the pandemic were more likely to be admitted to hospital, because admission to hospital or care in hospital was one of the criteria to have a COVID test initially. So it seems like they were more likely to be admitted, but that's likely a part of the selection. But yeah, so it is a very selected cohort of patients and speaks to the problem of comparing this to other cohorts. So the question we wanted to know, do we see more venous thromboembolism in these patients? So we started to look at the crude numbers of pulmonary embolism and DVT. So the total is here of VTE for each year, and as you can see, it's quite a flat curve. There's really not that much variation between the years, and there's definitely no signal of increase in 2020. And if we look specifically at the 2020 cohort, we have our COVID positive group, our COVID negative, so confirmed COVID negative, in sort of proximity to the test, and then we have the COVID unknown, where we don't have a test. We see that there was no difference in prevalence of patients that did a test for VTE. So the prevalence of VTE was quite similar at 17% in all these groups, and there was no statistical difference. Additionally, if we go back to, we wanted to see in the different cohorts, the admitted cohort, the outpatient cohort, we tried to divide up the cohort in 2020 by admission status. And then we see quite a large difference in the specific cohort of patients in the ICU. So the red bar is the COVID positive patients, and the height of the bar is the prevalence. So the prevalence of venous thromboembolism was really high. It was 70% in the ICU group, and the comparison, the yellow bar, is from 2015 to 19, and then the prevalence was just 30%. It's still high, but it's not nearly as high as in the COVID positive patients. But in all other cohorts, the patients in the ward, and that was patients being treated in the ward for a minimum of 24 hours, the prevalence of VT was actually lower compared to all other groups, and that was similar in the outpatients. So outpatients would be patients that did the test as from a clinic or from the emergency department, and admissions would be those that did the test in close or within 24 hours of being admitted, either to the ICU or to the ward, and that was lower as well, and there were no patients actually admitted straight to the ICU from the emergency department with a positive test in our study. Okay, and the last thing we wanted to check was, well, are there confounders in this that still plays a role, and is a positive test for COVID associated with an increased likelihood of a positive test for VTE? So we did a simple logistic regression model or analysis with all our confounder variables, and the short answer is that the only thing, and you see I put the confidence interval, so the number, the point estimate, is the odds ratio, and the range is the 95% confidence interval. So previous VTE was significantly associated with having a new VTE, which is sort of known. And then we have some, like previous malignancy, female sex, ICU care, and Charleston score, which is a comorbidity score that was associated, but the confidence interval cross one. Age was somewhere in the middle, and we can talk to that if that's interesting. And then we have others. So treatment with anticoagulation had a significantly decreased the risk of having a venous thromboembolism. And COVID-19, so a positive test for COVID-19 in proximity to the test actually had a lower likelihood of having a positive test for VTE. But as you can see, the confidence interval crossed 0 here as well. So we can't conclude anything really other than, at least it didn't seem like it was associated with an increased risk. So there are some important limitations to understand when interpreting this data. So it is a selected cohort of patients. So these are only patients that have been considered for venous thromboembolism, and where a physician has actually decided to work or to investigate the patients for a venous thromboembolism. So the denominator for the prevalence is still patients undergoing tests for VTE. We were limited in the number of confounding factors, so we don't have any vital signs, for example, when which is a known risk for venous thromboembolism. And the power, we were limited by the low number of positive COVID patients in the study as well. And then, as I alluded to in the beginning, it is hard to quantify what normal practice were during the initial part of the pandemic. And the comparison with 2015 to 19 gives us some sense, but it's still really hard to know how the changes due to COVID played out for the decision to test or investigate a patient for venous thromboembolism. But at least we could, in this study, we could see no general increased risk for venous thromboembolism with COVID-19 when adjusting for other factors. There were a high prevalence of venous thromboembolism in the ICU cohort, which was comparable to the prior evidence I showed. But we could see no general trend towards an increased prevalence in 2020 compared to 2015 to 19. Okay, thank you very much. That was all I had to say.